Hello, everyone. Welcome. My name is Caitlin, and we are so pleased that you could join us today. Welcome to the Improving HPV and Pediatric Influenza Vaccination Rates in Louisiana webinar series. Today's presentation will be on HPV vaccine, immunological and biologic responses, and the impact on communities. Our hope is that today's webinar series becomes a virtual community and a place to learn and share. During this webinar, you will hear from experts and have the opportunity to ask questions of the presenter and your peers. Here is a quick overview of our agenda today. This educational series is made possible through funding from the American Academy of Pediatrics and brought to you by the American Cancer Society, the Bureau of Family Health, School-Based Health Centers, Louisiana AAP, Louisiana Office of Public Health Immunization Program, Louisiana Primary Care Association, the Louisiana Shots for Tots Coalition, the LSU Health Science Center Dental Program, and the Southeast Louisiana AHEC. This webinar has been accredited for 1 AMA PRA Category 1 credits for physicians and 1.1 contact hours for nursing education credits. All improving HPV and pediatric influenza vaccination rates in Louisiana Planning Committee members have indicated they have nothing to disclose. This session is being recorded for educational purposes. A video recording of this presentation will be shared following today's presentation. By participating in this webinar, you give your acknowledgement and consent for recording. As such, please ensure that all patient privacy is protected. Do not provide any PHI during today's Q&A period. Please make sure your microphone is muted during this session. You will have the ability to mute and unmute yourself to participate in today's call. If you have any IT difficulties, please reach out to Ashley. You can call or text 225-505-7611. and she'll be able to assist you. If you do have video capability, please enable it during our Q&A portion of today's call. It makes for a more interactive and engaging session if we can all see each other. Finally, if you haven't done so already, please enter your name and where you're from in the chat box. This way we can all get to know each other better and we can capture your attendance. So today's webinar is HPV vaccine, immunological and biologic responses, and the impact on community. Today's presenter is Dr. Luke Wall. Dr. Wall is Associate Clinical Professor of Pediatrics in the section of Allergy, Immunology at LSU Health New Orleans. He sees patients through Children's Hospital New Orleans, including satellite locations in Covington and Baton Rouge. While his career is clinically focused, he enjoys balancing the medical care of children with clinical research and teaching. In addition to teaching pediatric residents and subspecialty fellows, he teaches medical students both in the lecture hall and at the bedside. He also participates in interprofessional education involving dental, nursing, medicine, and allied health schools. His clinical and research interests include primary immunodeficiencies, pediatric chronic cough, and genetic syndromes which have increased risk of infections. So with that, I'll now turn it over to you, Dr. Wall. Please start whenever you're ready.
Thank you, Caitlin, so much for that introduction. A year now of Zoom conferences, and I still forget to unmute myself. So if I forget anything else, please just drop me a friendly reminder. But let's see if I can share my screen here. Let's see.
Perfect.
Okay. All right. So I really greatly appreciate the opportunity to speak today. And I have really enjoyed going back and listening to the previous talks in this webinar series. If you have not had a chance to do that, I would certainly highly recommend that. Just of note, my talk probably links most closely to the initial talk of this series, Dr. Bocchini's HPV 101 lecture. Certainly, I will not have a chance today to repeat the wealth of knowledge that he presented in that talk. However, what I plan to do is hone in on a few specific, very unique aspects of the HPV vaccine and why and how it is used, and to really highlight the immunologic underpinnings of those decisions and those recommendations. With the thought in mind that, of course, knowledge is power, as we all know, and certainly when it comes to counseling parents or teens or patients regarding immunizations, the more knowledge that we have, the more effective that we are likely to be. For CME purposes, I have no relevant disclosures. So starting just briefly highlighting the facts of human papillomavirus and the HPV vaccine. So these three facts are very, very high yield. And really, if we can stick this away and recall this alone when we're counseling parents and teens or preteens regarding the vaccine, I think this really is the most essential information. So HPV prevents 90% of, the vaccine prevents 90% of HPV-related cancers. The vaccine can also prevent 6 different types of cancers. So it's not cervical cancer alone, although that's a huge piece of the protection. There are many other types of cancers. And 4 out of 5 individuals will contract HPV in their lifetime, especially if they're unimmunized. This fact, to me, really takes all the stigma away from this whole concept and this whole conversation about HPV. It is a very common virus. While it certainly is often sexually transmitted, it is very, very common in the general population and will affect about 80% of individuals. And screening alone certainly is not enough to protect patients from HPV-related cancers. As we know, cervical cancers and precancerous lesions are screened for, but the other types of cancers here on the list, oropharyngeal cancer, anal cancer, vulvar and vaginal cancer, and penile cancer, really have no real standardized screening approach. In addition, as you noticed here in the diagram, the cervical precancers are a huge portion of the iceberg. And so these are very common. They require, once they are identified, they require multiple visits, multiple procedures and surgical procedures often, and those procedures can lead to complications down the road. So certainly if we can prevent that, we are preventing a huge burden from individuals in the population. So moving forward to a little bit about the virus and the vaccine. So human papillomavirus is a non-enveloped double-stranded DNA virus. It has an icosahedral shape, which means that it has basically 20 plane faces in its geometric shape. The L1 major capsid protein, which is the primary antigenic protein, the main thing that's recognized by the immune system, is arranged as 72 surface pentamers, which you see here in the cartoon as these little groups of 5 teal green material. And we'll look at that more closely in this next diagram. And so this is described as the L1 pentameric capsimer. It has a capacity to self-assemble to form the virus's outer shell. And this concept of self-assembly is exploited and used in the HPV vaccine technology. And we will repeatedly refer to this as VLP, or the viral-like particles. And so here in this cartoon, you can see on the right the just natural wild type human papilloma virus. And you can see here it's depicted the viral DNA in this virus. Notice over on the left, these are just simply the L1 capsid proteins that are taken and self-assembled, and they look just like the virus. They are recognized by the immune system and very potent to stimulate an immunologic response, just like the virus, but they have no viral DNA. Therefore, they cannot replicate, they cannot cause infections. There is no live virus in the vaccine. And this is just a cartoon, just diagramming how the vaccine is made. So the genes are transferred into yeast, specifically in the setting of the current 9-valent HPV vaccine. And then the L1 protein is expressed by those cells in culture. And the L1 protein is the only thing extracted from this. So again, all of the DNA, genetic material, et cetera, is left behind. The L1 protein then undergoes self-assembly of the viral-like particles that is purified, and the vaccine is prepared. Therefore, when a person contracts or is exposed to HPV, they are already primed from the immunologic perspective, and antibodies are there and ready to bind to the virus and prevent the primary viral infection. There's also, of course, a T cell response, other components of the immune system that respond, but the antibody response is what usually is relied on.
Yeah. I'm sorry.
In measurement.
But his sounds 1 o'clock.
So just once again, this is not a live vaccine. There's no genetic material transferred. And because it looks so much like the virus itself, and these are highly potent proteins to stimulate an immune response, it is highly effective. So this vaccine, the HPV vaccine, has very unique age indications compared to other vaccines. And so I wanted to look at the immunologic concepts that underlie those recommendations. So HPV vaccines are prophylactic. In other words, they prevent new HPV infections. HPV vaccines are not considered to prevent progression of HPV infection to disease. They are not considered to decrease the time of clearance of HPV infection, and they are not considered to treat HPV-related disease. Now, some ongoing studies are continuing to investigate what role HPV vaccine might play to some degree with these concepts. But generally speaking, prophylaxis or preventing the initial HPV infection is the most effective approach. That's the main reason that the vaccine is recommended by the CDC for routine administration at age 11 to 12. And the vaccine the vaccine series may begin as early as age 9. And catch-up HPV vaccination is now recommended for all persons through age 26. Note there is no longer a recommendation specifically based on male or female, but this is for all preteens through age 26. So specifically, looking at the immunologic aspect of this, not only is it important to get the vaccine in very early to try to prevent that first HPV infection, but also we have the advantage that children less than age 15 have a much stronger antibody response to the HPV vaccine compared to those age 16 and above. This figure basically highlights 4 different HPV serotypes included in the currently available vaccine. And you can see the x-axis is age, starting at age 9 up through age 23. And the y-axis is the log of the geometric mean titers, or basically just the way that they represent the antibody response to the vaccine. And you can see that in the younger age, the response really is several fold higher than it is in the older ages. And look, even if you look at the spread between age 9 and age 15, those 9 and 10-year-olds really have quite a robust antibody response. So there you have another advantage to getting the vaccine in those preteen years. So what about the rationale behind offering the vaccine for adults aged 27 through 45, so beyond the standard recommended age range? So the public health benefit of HPV vaccination in this age range is really minimal. However, it is still considered effective for the individual, and people of this age still have appropriate seroconversion or antibody response, and adverse reactions are very, very low. And so this is why it's recommended to have shared clinical decision-making. People in this age group should simply just chat with a provider to decide if they are not already immunized, if the HPV vaccine is right for them. So why is the dosing schedule different by age group? So here are the current vaccine dose recommendations. Age 9 to 14, 2 doses, with the first shot given at the baseline clinic visit. And then the second shot, there's an appropriate window of 6 to 12 months after the first. So this really gives the advantage that one shot can be given at one annual well visit, and the second dose at the next annual well visit. Or there's flexibility there based on your practice. If you prefer to bring someone back in at 6 months, that is perfectly appropriate. In one of the previous talks in this series, Liza Smith really emphasized that practitioners that start immunizing at age 9, and especially taking advantage of this 1-year window, really have very, very, very high success rates at getting their preteens covered with appropriate immunization and completing that series. Any individuals in this age range who are immune compromised should receive the 3-dose regimen. And then for those age 15 to 26, the 3-dose regimen is recommended. So second dose at 2 months, and then third vaccine at 6 months. All right, so where does this information come from? This was the primary clinical trial that ACIP referenced when making the recommendations for allowing a 2-dose series for boys and girls. And so this study, the main objective was to demonstrate non-inferior immunogenicity of a 2-dose 9-valent HPV vaccine regimen in boys and girls compared with basically what they used as the control group. So compared to a 3-dose regimen in women, which of course has been implemented over a longer period of time. We have more outcome measures, et cetera, in that sort of age group. So to really understand the basics and the basic findings and importance of this study, we need to just briefly look at a few definitions relative to these types of studies. So immunogenicity describes the ability of a substance or a vaccine to provoke an immune response. It also can be used to refer to the strength or the magnitude of the immune response. Non-inferiority trial, or these are often really conducted as non-inferior immunogenicity trials, if you will. And so according to the WHO, this is basically what is recommended to be used when you have one agent, a vaccine, for example, that is already approved for use, it's already been proven to be effective, and you want to take and seek approval for another similar vaccine, or in the case of this study, you want to basically change something such as the dose interval. And so the goal is for the FDA in the US, you really have to prove that your new approach is not inferior based off of the immunologic response to what is already accepted. And then what do we really mean when we say vaccine efficacy? So also according to the WHO, the vaccine efficacy is an estimate of the reduction in the chance or the odds of developing clinical disease after vaccination relative to the chance in unvaccinated individuals. So notice that it really focuses on clinical disease, not an immunologic response per se. And so in the setting of HPV vaccine, that clinical disease may be precancerous lesions of the cervix, or that disease may be genital warts, or cervical cancer, or even head and neck cancers. And HPV is currently the #1 cause of head and neck cancer. So those diseases are what are really referred to when we talk about vaccine efficacy. So consider, in the setting of HPV, that measuring this would really require quite a prolonged follow-up to truly measure efficacy. Even if we wanted to look at sort of a first step of, or sort of a first marker of disease, such as precancerous lesions of the cervix, most of the studies looking at that are at least 3 years out from the point of vaccine. Studies measuring incidence of cervical cancer, many of those are a decade or so out from the immunization. So you would need quite a prolonged period of time. You would need quite a high number of subjects. And this is also very impractical regarding the administration of HPV in pre-adolescents, because remember, we're really trying to immunize them before they initiate any sexual activity. So this really brings us to the concept of immunobridging. So with immunobridging, specific immune response parameters, which are already known in a group in which the vaccine is effective, for example, HPV vaccine in women, can be used to study the vaccine in new groups. So this is measuring sort of the immunologic, or taking the immunologic response that is already known in a group in which we also know that efficacy is there, that the intervention was protective against disease. So looking back at that immunologic marker that was used after the vaccine, we can form new studies and compare the new studies, compare just simply the immunologic response in the new study to the immunologic response in another group in which efficacy was established. So this supports extrapolation of efficacy among populations or interventions. Although remember, efficacy in and of itself, prevention of disease, is not truly being measured. And so for the licensing of the 2-dose regimen, basically the study really relied on immunogenicity and immunologic bridging. And so for this study, 1,377 participants were analyzed. These were in age 9 to 14, male and female, compared to age 6 to 26 female group as the standard or control. There was a 97% seroconversion to all 9 serotypes used in the vaccine. And then the titers were significantly higher for all 9 serotypes in the younger age group, in the age 9 to 14 year, receiving the 2 doses, compared to females aged older teens and adults receiving 3 doses. So 2 doses in the younger children was very effective. And immunogenicity was found to be non-inferior with the 2 doses in persons aged 9 through 14, compared with 3 doses in a group in which clinical efficacy had already been demonstrated. And so this is where we get the okay, or the yes, it really looks like this is an acceptable approach to use only 2 doses in those prior to age 15. Just a comment on the duration of protection of the HPV vaccine. Most of the information regarding this is available for the older series, the older recommendation of the 3 doses. So 10-year follow-up data protection does not wane. For the 2-dose series, antibody kinetics so far are really very similar to 3 doses. And so long-term protection is expected from the 2-dose series. So what about use of 2-dose in teens over age 16 and adults? It seems like if it worked so well in those younger, then it would work very well also in the older group, but that has not been studied, at least no large-scale studies as of yet. So perhaps to come. So how does the HPV vaccine induce such robust immunogenicity? So here on the left is a little cartoon of a surface of a B cell. And these little purple things, if you will, are the B cell receptors or the immunoglobulins attached to the B cell surface. And then you see signaling down through the cells represented by the arrows. And these little things that look like cotton balls, those are basically proteins or protein complexes that are recognized by the B cell receptors and then stimulate a response in the B cells. Remember, the B cells are those cells that make antibodies, make that antibody response. And so you can see on the left when there are just pieces of proteins that come in, yes, there is a B cell response, but not nearly as strong as this complex that is formed by this intact viral-like particle when it attaches to the B cell surface. You can see that it really stimulates multiple B cell receptors simultaneously, which leads to a very strong antibody response. It really stimulates the B cells and therefore stimulates the immune system in quite a potent way. So we really think that this is the underpinning of the reason that in nearly all studies, over 95% of subjects have very strong antibody response, and the reason why that antibody response is very long lasting, with the HPV vaccine. A few words about special populations related to the HPV vaccine. So in the immunocompromised, they are prone to viral infections, nearly any viral infection, of course, including HPV. They also have impaired viral clearance, meaning that once they contract HPV, they may not clear it as readily as the general population. They also are prone to development of malignancy due to immune dysregulation. And they're also prone to severe and refractory papilloma due to HPV. So large masses of warts or mucosal tissue that becomes very enlarged and proliferative due to the HPV vaccine. Because of all of these reasons, the 3-dose series is recommended in the immunocompromised. What about children? So in infants and children, oropharyngeal HPV can be a problem. For infants who have difficulty with this, it can compromise the airway. It can require repeat surgeries. Even if the entire papilloma is essentially debulked, then it often recurs. And these lesions can also undergo malignant change. Here in the photo at the top, you can see HPV lesions or warts on the buccal mucosa of a child. And here in the bottom frame is actually a papilloma sitting on the vocal cords. And so you can picture how this could cause airway compromise. This is just a recently published study, just came out in March of this year from Finland, surveying oral HPV prevalence in children. And they noted a nearly 23% prevalence of at least one HPV serotype at birth. Now, the majority of those children went on to clear the HPV, and therefore approximately 9% continued to have detectable oral HPV at age of 3 years old. Persistent oral high-risk HPV type in children was associated with oral HPV carriage of the mother at the time of delivery, as well as seroconversion of the mother to the high-risk HPV during follow-up. So showing that basically the mother had the same HPV type. Additional evidence for vertical transmission of HPV. As far as pregnancy, the HPV immunization is currently not recommended during pregnancy. However, this statement really is simply based on limited clinical trials data. Pregnancy screening is not recommended prior to administration of HPV vaccine, and keep in mind that this is recommended in women of childbearing age. Also keep in mind that this is not a live vaccine. Therefore, there really is no plausible biologic or virologic reasoning behind any potential adverse outcomes in pregnancy. And there is no association of HPV vaccine-associated adverse events documented in available studies. This is one such meta-analysis looking at HPV vaccination in pregnancy. This looked at a compilation of multiple studies over the previous 10-year period in which various registries, et cetera, from multiple countries documented the number of times in which HPV vaccine was inadvertently or unknowingly given to a pregnant woman. And they really had thousands of instances of this worldwide. None of the relevant studies found a significantly increased rate of spontaneous miscarriage, and there was no indication of HPV vaccine-associated adverse events in pregnancy. This is a specific study out of the US through the CDC's vaccine adverse event reporting system. So they took all reports of HPV administration, inadvertent administration to a pregnant woman in the US from 2014 to 2017. There were 82 reports in total. Of 72% of the reports, there was no adverse event at all. In fact, the report was simply just made because it was realized that the vaccine was administered to someone who was already pregnant, no adverse event. And 3% spontaneous abortion was documented. This, however, is expected to happen in up to 20% of pregnancies in the US and the general population. And 2% reported vaginal bleeding. Vaginal bleeding is expected to occur in approximately 12% of pregnancies in the general population. So really there was no increase of adverse events documented through the VAERS system. So as far as current studies, ongoing studies, and new information. So just some interesting ongoing studies. So the single dose regimen is being investigated. By the way, some of these are in the US, some of these are in other countries. Also, a flexible 2-dose interval is being investigated. The WHO has made a statement that in the setting of, especially in underserved countries, in the setting of the HPV vaccine not being readily available in appropriate doses, get 1 dose in, follow it up with a second dose 3 years or more down the road, you're probably okay. However, there really is not any data supporting that statement. And so that is being investigated. Administration of the HPV vaccine in postpartum women, which is a great time where providers often have time to sit down and really talk with mom about a lot of things. Baby is often being given their first immunization in the nursery. Immunization conversations come up in general for the baby anyway. So it would be great to be able to administer or offer the HPV vaccine to a woman in the postpartum period. The safety of that is being investigated. And then also administration with excisional therapy in women with cancerous or precancerous lesions of the cervix is being investigated. As far as new information, so this was a National Health and Nutrition Examination Study, or more commonly known as NHANES study, just published about 6 weeks ago, in which they investigated the decline in prevalence of HPV vaccine type infections among females, comparing recent years to the pre-vaccine era. And they found a significant decrease in, they looked at the serotype, the types that are specifically available in the 4-valent HPV vaccine. They found a significant decrease in teenage females of 88%, as well as a significant decrease in young adult females of 81%. What I thought was even more remarkable is from the same study, comparing the same timeframes, unvaccinated females demonstrated an 87% decrease for teens and a 65% decrease for young adults. So this demonstrates, or really supports, evidence of a significant herd effect of HPV. And for the authors of this study posed that this was really likely attributable to the widespread uptake of HPV vaccine, not only in females, but also in males, which has been recommended since 2011. So in summary, the HPV vaccine is highly effective. It induces quite robust immunogenicity, in fact, more so than many of the other vaccines. It gives strong and long-lasting protection. The antibody response is the highest for those less than 15 years of age. It is safe and it is recommended for the immunocompromised. As far as pregnancy, there is lack of clinical trials data, so it is not recommended. However, there is no biologic plausibility for adverse outcome, and no statistically significant adverse outcomes have been documented in available reports. So vaccinate early, capture that preteen age group. In this group, you have the advantage of higher immunogenicity. You have, you're wanting to achieve that goal of preventing the first HPV infection. And hey, practical talking point when it comes to parents, only 2 doses are needed if you start in this age group. So with that, I would like to really thank you for your attention today, and thank you for the opportunity to allow me to speak.
Thank you so much, Dr. Wall. That was a wonderful presentation. Ashley, were you going to say something?
No, I was just going to echo what you said. This was really interesting and great data that some of this I haven't heard before, and I've heard a lot of HPV talk. So I absolutely appreciate that. I'll kick us off with a quick question. So the NHANES report that you just shared, the data was specific to females. Did it look at males as well, or just as females based on kind of what the clinical recommendations have been in the earlier years?
Thank you for the question, Ashley. So that specific study really just looked at females, and they also restricted the study to the 4 types of HPV that were included in the previously available vaccine in the US, the 9-valent vaccine. And that is because of 2 reasons, really, because they really looked at such a wide swath of time. And they also were looking back to compare times, before the HPV vaccine was even available for males. And then also because the analysis of the actual virus which the subject had at the time, that information was obtained from self-administered vaginal swabs from the study volunteers. So that the study specifically really only focused on females.
Great.
Have there been, I'll just ask, have there been any research that has come out that has male data included? And if some other countries have been doing that much longer than we have. So just curious. I know it's important that we really just keep the conversation to all teens get vaccinated and try to help folks no longer think of this as a female vaccine. So maybe that data can help drive that discussion.
Yes, absolutely. And so it is expected to be protective for males, and then also to give that advantage of herd immunity, if you will. so that, you know, not only HPV goes down in males and females, but also, you know, even in children, you know, as we highlighted, even, you know, you know, even if we're not taking care of adolescents, even if there are people in the audience who their primary population is the newborn nursery, you know, it's still a very highly relevant topic. And as we mentioned, it's relatively common to be able to detect HPV even in the newborn infants.
Do we have any other questions? And feel free to come off mute or put your questions in the chat box and we can ask them for you.
Dr. Wall, you did such a great job of explaining everything that people just know it all now. They don't even have any questions for you.
All right, well, I certainly appreciate the opportunity to talk. And for everyone in the audience, I know it's a multidisciplinary group. We're all from different backgrounds, et cetera, but we all have some role to play in medicine in some way, shape, or form. And thank you for your service over this past year. It's been quite a challenging one, obviously, in the setting of this pandemic. And we will get back on track. I think we already are beginning to get there, hopefully. And of course, getting back on track with immunizations is a major, major piece of that.
Yeah, absolutely. And thank you so much again for your time and for sharing such great information. And I'll say in public health, we don't often look at the immunocompromised. So it's really nice to kind of see that side of it as well. And that there's still great options for those folks. So thank you so much. And just a quick reminder to our attendees, you should have received an email from AAP staff requesting mailing addresses for resource materials. Please fill out that survey for us. If you have any questions, reach out to Ashley and she can help connect you to that survey. So thank you guys so much and thank you for joining us today.